I'll be talking about application and reliability of Corvis ST in clinical scenarios, which includes cases which are, beyond keratoconus, some of them with keratoconus as well as refractive surgeries. So we'll be going through these case scenarios. And this we've already learned from the previous talks that whenever you have a softer cornea, the applanation length, the arc length, the stiffness parameters would decrease, and so would the ARTH. Now, this is just to show a frank case of keratoconus, which on Pentacam shows that the bad is abnormal, and likewise on the biomechanics as well. When you see the TBI, the CBI, as well as the bad on the biomechanics map. And this is a same patient. One eye has got mild keratoconus, the other eye has got severe keratoconus, which can be highlighted. And on this dynamic corneal response curve, again, you can see that the various parameters are also altered, like the applanation length, the arc length, the DA ratio, and because it's mild, the values are altered less here as compared to severe keratoconus, where they are altered more. If you compare the two fellow eyes of the same patient. Now, if you look at the CBI, TBI, and the BAT, then one realizes that these biomechanics are good for the cases which are mild, or for the cases which are subclinical, or for the cases which are form first. But when it comes to the grades of severity as to moderate or severe, it's not able to distinguish between them, because beyond a particular value, it does not increase. So it is, although the grades of keratoconus in terms of severity are so different in both the fellow eyes, but the values of TBI and the TBI and the CBI would be, nearly the same. Only the bad is the one which is higher in this eye because of a more severe keratoconus. So this is just to show the deformation maps of the same, and then again you can see that in mild keratoconus the deformation will be much less, because it's a stiffer cornea as compared to severe keratoconus, where the deformation will be much more. Now, this is just to show a case of vernal keratoconjunctivitis, which had pachymetry, which was good, almost to the tune of 550 microns. Keratometry also, which was good. The bad is also normal. But if you look at the biomechanics, the biomechanics are falling in the range of a suspicious category, 0.38, and then TBI of 0.35. So these cases actually have to follow up over a period of time, and especially when it's a child, then you know that you have to follow up these cases over a prolonged period of time, because they may have keratoectasia. Now, this is yet another case of vernal keratoconjunctivitis only, and here notice that the here notice that the keratometry Kmax is about uh, ranging from 42 to 45.8, and the pachymetry is also to the tune of 512, which is borderline. But these cases, they need to be followed up, because the CBI and the TBI, they are all falling in the suspicious category. So these are and this is a child. So we need to follow up these cases on the biomechanical parameter as well. Now, this is just to show a case of pediatric keratoconus, which is symmetrical in the right eye and in the left eye, both of them. It is so symmetrical that the maps also look absolutely symmetrical. And again, if you look at the D values, they are also symmetrical, 6.3 and 6.31 and 30 here. And if you look at the CBI and the TBI, they also are so symmetrical. So in very severe cases, I think biomechanics is something that has to evolve, and that has to go into further research. The manufacturers will have to, titrate their readings for more severe cases, uh, as per the uh, as per the machine, as far as the machines are concerned. Now, this is a case of PRK, where a case where PRK was done, and as you do the PRK, notice that the cornea becomes flatter. The pachymetry also decreases, and the anterior curvature maps change. The posterior corneal elevation maps, they remain same in the pre and the post-operative period. And if you look at the dynamic corneal response in these cases, again, notice that there is a decrease in the deformation amplitude to some degree, and the applanation length also decreases to some degree. And this is in the post-op period of PRK, and the CBI after the laser vision correction, which the machine detects is zero point 0.0, which is in the normal range, which means that the PRK does not really alter it too much. And if you see the pre and the post-op picture of a PRK, then and again this highlights the fact that the cornea is not that much altered, and it doesn't become very soft after PRK. On the other hand, if you look at the LASIK maps, again in this, the maps, you can see that the cornea becomes flatter. The posterior, the pachymetry also decreases. The posterior back elevation remains almost the same, and the anterior elevation is the one which changes. And again, if you look at the post-op picture here, the CBI LVC, the biomechanical tomographic assessment will show that the CBI is zero point 0 in this case. And if you look at the DCR again, notice that the applanation length would get altered, and so would all these parameters, as is expected after the LASIK surgery. Now, this is a case of post LASIK ectasia, and in this case, as expected, the D value is altered, and so are the other parameters on a dynamic corneal response. And this is a case of SMILE pre-op and post-op, where again the anterior part of the cornea is the one which has gone alteration. The posterior one has not got any alterations. And again, if you look at the CBI and the TBI, the pre-op is 0.35 and 0.01, and post-operatively the CBI is 0.07. So the SMILE really doesn't alter it too much, although it does alter it slightly, as is seen in these parameters of arc length, DA ratio, as well as the inverse concave radius ratio. And if you look at on the video images, again the response of the surgery is not that perceptible, because if you compare it with LASIK, then of course it is much better in terms of the corneal biomechanics. Now, this is a case of post-LASIK ectasia for which intacs and collagen cross-linking has been done. And if you look at the densitometry values, and this has been reported by Dr. Ambrosio, that these values, when you do a collagen cross-linking, would increase. So here it is 29, and it has increased to 31. So this is expected, especially in those cases where collagen cross-linking has been done. And this area of flattening, this blue area has increased, and this yellow area has decreased, and this was the only change that was seen post-operatively after 1 month in this case. So again, this is to show the CBI values, which are showing 0.0. And I think again, in such cases, the machine needs to, also need to know how these cases are going to be read, because these are complex surgeries or multiple surgeries. Now, we also wanted to see our corneal transplantation cases. So this is just to show where the sutures are intact in an operated case of penetrating keratoplasty. Notice that there is no ectasia at all present, but this is a case of keratoplasty where sutures are out, and the peripheral part of the graft is looking ectatic. Again, the D value is 1.7, and here, of course, the D value is very much increased because of the ectasia part. And if you again look at the CBI and the TBI values, they are again showing that it is very much increased in the case where ectasia is present. We also looked at our cases of DSEC, and in this we could not find anything perceptible except for the fact that the corneal thickness is increased, which is expected in this case. And again, I think it is important that the biomechanics of not only the host cornea, but biomechanics of the donor cornea should also be studied, which includes the DSEC as well as the DMEC. And that is something again where the manufacturer needs to work on the Pentacam machine and the Corvis machine, because as of now we are not geared to study cases of corneal transplantation, whether they are sutured or whether they are sutureless. So this is again a post DSEC case. It doesn't give you anything much except for the fact that CBI is 0.84 and TBI is 0.56, but the corneal thickness is increased. So one doesn't know how to actually correlate these values with a double cornea that such cases generally have. So, to conclude, the standardization of the normative data in different ethnic groups is required, and I think it is going on in different geographical locations because these would be different. The limits of the diagnosis of the study of biomechanics need to be expanded beyond form first keratoconus, subclinical keratoconus, and early keratoconus. And it should be more inclusive to include cases of other disease pathologies, including corneal transplants as well as donor corneas. And I think we are still in the stage of infancy, but there's a potential to change the whole new world of biomechanics as we get smarter and smarter into it. Thank. I would like to acknowledge Professor J.S. Tityal, Dr. Rahul Bafna, and the staff of the LASIK Lab for helping me with this presentation. Thank you very much for your kind attention.